Welcome back. This session is called From Implant to Retrieval, Mastering Dual Leadless Pacing Techniques. For this, we recorded a case at my center, St. Bernard's Medical Center in Jonesboro, Arkansas. First, I'm delighted to welcome our expert panel, Rahul Doshi from Scottsdale, Mikhael El-Chami from Atlanta, and Vivek Reddy from New York. Now let's take a look at the case. Can I have the case, guys? Thank you. All right. So for this session, I will focus on the dual chamber leadless pacing system and some of the techniques for implanting the system. If you could help advance the slides, please. These are my disclosures. So the AVER dual chamber leadless system combines three components. So there's the leadless pacemaker, both the atrial and the ventricular devices, the delivery system, the retrieval catheter, and the introducer, and then, of course, the AVER link module and the Merlin programmer that kind of bring the system together. Now, the atrial device and the ventricular device kind of look the same, but they have some subtle differences. Both of these are helix fixation devices, but the atrial device does have a dual helix design. So there's an inner helix that acts as a pacing electrode and provides additional fixation and additional electrical stability. It is shorter than the ventricular device. It's about 32 millimeters, but both of them have a docking button that allows for fixation as well as retrievability. You can see the ventricular device, again, has an active fixation helix, but the cathode is at the tip. It sits mounted and allows for pre-mapping. Both the atrial device and the ventricular device allow for pre-mapping. Both of the helixes have anti-rotation sutures, so it also gives stability to the device. Both devices have a high-capacity battery. The ventricular device has a bigger battery. It's a longer device and also has that docking button that allows for implant as well as retrieval. Now, the recommended atrial implant sites are the base of the appendage. Even though it is the base of the appendage, you can implant it in other locations, such as the lateral wall or the Bachman's bundle, the interatrial septum. This is the most ideal site, at least out of the AVER DR trial. For the ventricular device, the ideal site is the low or the mid-septal area. The only sites that I truly avoid are the apex and the basal septum. Just apex because of safety and the basal septum because of the length of the device and any interaction with the tricuspid valve. So let me take you through this case really quick and go through the steps of the procedure. My patient's a 72-year-old male that was admitted with syncope and shoulder fracture. He's got slight dementia. He's has COPD. He's on low-dose steroids. Has a normal echo except for moderate aortic stenosis. ILR showing long pauses corresponding with his syncope and a low BMI, which is not very common where I come from. Having said that, to me, a patient like this it's a relatively older patient, has malignant bradycardia, needs pacing. But from an AVER standpoint, to me, this patient is going to need a quicker recovery. They've had a shoulder fracture. It is a high-risk patient, whether you use leadless technology or a transvenous technology. They have a normal ejection fraction. So I do believe that this is potentially a patient that would benefit from both atrial pacing and potentially maybe need for ventricular pacing in the future. So if you could please play the video. So I'll just walk you through my workflow here. If you could click that video for me. So we get access with ultrasound. We pre-close. For my DR systems, I use intracardiac echo for visualization. So here we are establishing communication with the programmer. We take that protective sleeve back. I'm starting with the ventricular device implant here. We deflect low into the right ventricle. You can see that on ice. I'm not trying to position on ice. Usually for the right ventricle, I'll do an angiogram, especially in RIO and LAO. In RIO, I'm looking for what I call the space sign, and in LAO, I'm looking for like a septal orientation. rotation. We're never truly quite on the septum. I don't think so, but you can see we have that septal orientation, and the way the helix kind of takes the bite, it kind of takes or engages the septum. At least that's my understanding. I will say that I have put this device in other sites in the right ventricle, and because of this capability of pre-mapping, which is what I'm doing right now, we actually check a blood pool impedance when we are initially unsheathed in the right atrium, and then we're looking for a contact impedance of at least I like somewhere between 400 to 500 range, and that tells me that I've contact. I look for an injury current, and I look for a good RV that tells me I'm in a good substrate. And once I'm in a good substrate, I do the fixation. It's about 1.5 turns on that chevron. So it's something that I do under fluoroscopy, 1 turn at a time, allowing for that torque to transmit. And once you deploy or implant that helix, you go take the device in, you undock the device, you do this, what do you call, deflection test to look at the stability. And the things that I look on stability are, one, electrical stability. So we're looking for the electrical numbers, looking for that injury current to go up. We're looking for that impedance to rise with every turn. So with every half turn or half degree turn, I want that impedance to go up by at least 100 ohms if possible. So the higher the impedance gets, the better. Somewhere in the thousands is I stop the rotation. So somewhere 1.5 to 1/4 to 1.5 turns is what I would do. And then I'm looking for the chevron and looking at the stability of that chevron and making sure there's no rocking motion on that chevron or the helix. What I'm doing here is I'm checking the distance to the base of the appendage. So you could you could implant the atrial device at the base of the appendage, either in the anteromedial sulcus or the posterolateral sulcus. And most of the time I go for the posterolateral sulcus, but if the right ventricle is enlarged or the right atrium is enlarged, I'll actually check the distance to the base of the appendage to decide where I need to go. So here I'm looking at an angiogram. With the use of ice, you really don't need a lot of angiogram, but because this was a recorded case and we were showing the technique, you can see we're looking at angiogram. You're looking at in LAO, you're looking at about 10 o'clock, 11 o'clock, and in RIO, you're looking at about 1 o'clock, 2 o'clock in the clock position. And here you can see we're unsheathing the atrial device. You can see on ice, my ice catheter is in the superior vena cava, and I'm looking at the appendage in its longitudinal fashion. We're looking for an injury current where we're off of the base of the baseline. You're again looking for a slight impedance. You're not going to see high impedances like the right ventricle. Somewhere in the low 300, upper 200 range is where I usually see impedances for the atrial device. And again, as we're fixating, we are looking for that impedance rise, but usually about, I would say about 20 to 40 ohm rise is what I have seen with the atrial device. Now with the AR2 device, we have started seeing a little bit of higher impedance. And then once we have fixated again, 1.5 turns on that chevron, we come into this tether mode. And for the atrial device, you'll see we're in this long tether mode, allowing for the device to have allowing for a better tension test and letting the device be in a more neutral position as we check for the electrical parameters. So again, looking at that injury current, the impedance, we're testing here. You can clearly see I'm pacing at about 90, and the patient is in heart block. So definitely a candidate for dual chamber pacing. So glad that we started off that way. But again, you can see once we have good electrical parameters, we've seen good mechanical stability. Again, looking at that chevron and the helix to make sure that there's stability and good implant characteristics, we're ready to release the device. Now, here what I'm doing is I'm again checking the distance between the two devices, and the eye-to-eye distance or implant-to-implant distance is one of the things that gives you a good AV synchrony. And if the devices are close to each other, then the there's less loss of battery, or there's more longevity in the battery when the devices are not too far apart, and better eye-to-eye communication. So here you can see the device. We just released the device, two nice stable devices, and we're measuring the eye-to-eye. The distance is about 56 millimeters here. Anything under 70 millimeters is adequate. And also you're looking at the orientation of the two devices between each other, and you're looking at a less than 40-degree angle. And that's a little bit harder to adjust. I think distance is a little bit easier to make happen, whereas I think the orientation of the device is a little bit harder to adjust. Now, most of the cases, I would say that I'm not actually waiting for the eye-to-eye communication to be set up in the lab. Once we have good implant and a good eye-to-eye, a good distance, I feel very comfortable doing this in the recovery room. But this, we did this in the interest of showing you this. Here you can see the VIP algorithm kicking in. The patient was atrial paced, ventricular paced when we started, and you can see the VIP algorithm has kicked in. We programmed initially this patient as DDD. Again, remember, this patient was under sedation. And once the VIP algorithm kicked in, we actually looked at the longevity in AAI. Obviously, I'm not going to program this patient as AAI. We do have the capability of programming this patient as AAI with the VVI backup mode now. And you can see at 2 weeks, we kind of programmed it that way from DDD. And you can see the longevity is significantly higher with that kind of approach. If I can just go back to the slides and maybe bring the panel as I move on to the next set of slides. So one of the beauty of the system is that this is a kind of a modular system. So you can choose the system to where you can treat the patient for a sinus node dysfunction, just do an atrial only implant, and then come back later and upgrade the device, or the other way around, where you have a ventricular device and upgrade later. And what I'll do is I'll let this video play, and I'll have the panel join me in a discussion. If you guys could play the video in the background. This is a patient that we planned for an AAI only implant in a sick sinus syndrome patient. So Rahul, I'll start with you and ask you, what is your implant been? Usually, is it always dual chamber, or are you going for AAI only implants a lot? Can you just walk us through that?
Yeah, I think I was actually going to ask your approach for the same exact issue, right? I mean, I think we've evolved, right? We were all enamored with the fact that we can put in a dual chamber device, and then forgetting that, oh yeah, this is upgradable and we can do atrial only. And then it evolves to, oh no, we can use AI with VVI backup, to now, quite frankly, for many of these patients, we are just putting atrial only in it, based on your paper and a variety of our experience. I think that's supported. But I was actually going to ask you, in this case, you demonstrated nicely with atrial pacing that, okay, this patient blocked, right? But here you put the ventricular device in first, and okay, then demonstrated after the fact, right? Are you doing things? And so this patient, I noticed, had baseline first degree AV block. Are there a particular group of patients that you would say, you know what, maybe I'll put the atrial device in first, I'll assess pacing from the A to the V initially, see what conduction looks like, and then decide whether to put a ventricular device? Or are you always putting the ventricular device in first?
No, I would say that this patient, like the one that's playing right now, you can see we started with atrial device, and I'm doing Venkibach testing, and I'll take it up to 140, 150. And you can see with Venkibach testing, there's one-to-one conduction, and I feel very comfortable leaving this patient with AI only pacing. And of course, this patient also had an ILR to keep an eye on their rhythm. In the other patient, he had malignant syncope. He was older. He had slight dementia. So just from the clinical, just a clinical perspective, in his pauses, he did not have any kind of escape rhythm with his pauses. So I felt with the fact that we do have the capability of AAI VVI, I just didn't feel comfortable not having the device as a backup. I mean, never know. And so you can see actually in this patient that we put AAI, he came a year and a half later with this on the ILR, and we actually had to bring the patient back for upgrade. But that's okay. I mean, it's not that high of a percent. At least in our experience, it's been under 10% that we had to bring our AI-only implants back for upgrade. Vivek, what's your practice been?
No, actually, when you showed this case, I had the same sort of reaction as Rahul. This might have been a patient that you would have considered doing AI AI only device, and consider, later doing a particular device if necessary. So I think the atrial only device strategy is an excellent strategy. It makes economic sense. It makes clinical sense. And, unlike when you're putting a traditional device, when you're sort of, you're already there's a surgical sort of procedure that you're doing. And yeah, it probably doesn't make sense to only put an atrial device. Here, I think it makes a lot of sense. And our experience is the same as yours, by the way. It's rare. I shouldn't say it's rare. So far, it's been infrequent that we've had to upgrade the patient. I'm sure we'll upgrade some of them, and that's okay. I have no problem with upgrading them later. So I think
Vivek,
I love the idea of that.
That point, I think, that you just touched on is such the critical one. And Devi and I have talked about this previously. It's very different thinking about upgrading leadless versus upgrading transvenous. And I think that's a fundamental message, right? You're not going into a pocket. You're not now perhaps increasing your risk again of thoracic trauma. We've talked about this previously, going back to Dan Pace, right? Comparing transvenous AI versus DDD, right? The message on that, even though it was, again, infrequent, 9% of patients were upgraded, right? From atrial only to ventricular in the trial, over, a good follow-up period. But their message was that, no, this is not good because you're upgrading transvenous and the risk associated with that. And I think we've got to flip the script now. That with leadless, it's a completely different approach, and you can afford to wait if you choose to.
Well, we have the same approach. A lot of our patients just get an atrial only device, and we also have similar experience, less than 10% upgrade to a dual chamber. I think an important, other than avoiding thoracic trauma, I mean, the most important thing is you avoid an infection by opening, that's why it's different than a transvenous device. If you need to upgrade, that's why it's an easier decision for us. Devi, I have a question for you. Could you, our
Mikhael,
experience...
can I have the team team just go ahead and play that next video while we take Mikhael's question?
Yeah, when you're implanting atrial device, I find myself relying a lot on the injury current and the impedance. And I've left devices with very high threshold, and I've seen the thresholds come down beautifully. Also use the differential in threshold using different pulse width. We have published our experience, and I feel very comfortable if I have a good injury current and a good contact, accepting high threshold at implant. And I've seen almost all of them come down within a few hours and the next day.
I have to agree that if I don't see if I get a good high threshold, or I wouldn't say good, a high threshold, I feel better. If I don't get a high threshold, I'm worried with this atrial device. I guess even though the helix is shorter, right? I think the footprint is so wide. I feel like that's what we see. We followed we check on the voltage as well as the pulse width as well. But to me, I think I feel comfortable when I see high. If I have capture and no phrenic issues, I will release the device without waiting. Especially now with ICE. I want to just ask about ICE, and Vivek, jump in. And what are your thoughts on? I use ICE for all my DR, all my atrial device implants. I know it can be done without it because half of the country does it without ICE. But what are your thoughts on ICE versus no ICE?
No, I 100% agree. I love using ICE for atrial implants. I don't use it for the ventricular if we're doing just VVIR devices. I don't think you do either. But if it's an atrial device or dual chamber, I think it makes everything so much easier. We don't typically use contrast. Not that there's anything wrong with that. I think it's fine. But I think it just makes it easier. Let me just make one other point. I think that, as oftentimes happens, technique evolves, right? So a couple of things I'll say. One, I 100% agree with everything that's been said about looking at the injury current and watching the rise in impedance to feel confident that you have a good position. And I agree that immediate thresholds are irrelevant as long as they're getting better. If they're not getting better over the next, over the subsequent, whatever, X number of minutes or whatever, then I think you get worried. Second point is, I think that, so for example, I don't do the tug test anymore. I don't do the deflection. I don't do any of that stuff. I think that the information, when you see the acute sort of response, whether it's in the ventricle, you have a delay in terms of the rotation compared to when you rotate, as well as all the impedance changes that you referred to and the SC changes, the injury current, I should say. In the atrium, it is true that you have the exact same thing. It's just less profound. You're not going to see the 200 to 300 ohm change, obviously. You're going to see, as you said, a 20 to 50 ohm change. So everything's a little bit more subtle, but when you see that, you can feel very confident about that. So I think that, that in concert with ice makes me feel very comfortable. I would also say that for people who are, let's say, doing this for the first time or early in their experience, I would definitely use ice, because all the next generation technologies, whether it's by this company or other companies, will probably benefit by using ice. Whether we're talking about, interventricular septal, that is left bundle area pacing, or, the sort of whatever the crux of the heart pacing you want to call it. So I think it's the most useful online imaging that we have next to fluoro.
Yeah. Well,
Can I
with
ask you
that, I
guys a
think it's
question?
important for us to talk about retrieval. Can I bring the next slide on, Rahul, and then go ahead and ask the question? I just want the team to bring the next video.
Yeah, while they're loading that up, I was going to ask all three of you, are there any absolutes with the atrial implant, right? In terms of, I'm not going to take this, right? We already talked about threshold. Do you use I have to have at least this impedance, like some people would say it has to be more than 300? Do you use that paper from that Japanese group that demonstrated if you've got, 2 millivolt P waves, or you've got that injury current that's significant, that you're not going to dislodge, you'll have good thresholds? I mean, are there any absolutes that you guys take, or is it just still relative, take everything in consideration, and again, you look for that
So,
difference that you...
so Rahul, we have a paper in Heart Rhythm where we've accepted no capture or a threshold of 6 at 0.4. But we had excellent injury current. When we checked the threshold at 1.5 millisecond, it was 4. And then within 10 minutes became 3 at 1.5 millisecond. And all of these patients next morning had a threshold less than 1. And most of the average threshold, I think, was 0.7. So as long as I feel I have good contact, good injury current, this hasn't been an issue for us.
Right.
Yeah, I
Threshold, we all
agree.
agree, right?
Oh, sorry, go ahead. No, I'm just sorry.
No, I was just
make my
making a
comment very
threshold.
quickly. Oh, go ahead.
Go ahead.
You should go ahead.
Vivek, go ahead.
Okay. Yeah, somebody has to quarterback here. No, I was just simply going to agree with
Yeah.
Mikhael. I don't think there are any absolutes. I think you have to look at the constellation of all the information you have, including the imaging, including the electrical parameters, and they have to make sense. The fact that they're getting better, if they're not getting better, you have a reason why they're not getting better, like an incredible impedance or actually, injury current. And part of it is, frankly, it's about comfort and time. If you wait a little bit longer during the procedure, you will see what you want to see. But at some point, you feel comfortable because you've seen this so many times. So, yeah, anyway.
I do want to bring up retrieval and long-term management of these devices. So if the team can play the next video while I bring the question up to Mikhael. Mikhael, how do you talk to patients when they're getting leadless strategies about their long-term management? Is it always, I'm going to have to retrieve them, or is that a big deal for you? Or
No, I mean, when I consider leadless for most of my patients, in my mind, this could be their last device, or they might need an extra device. Now, if I'm talking to a younger person, then I will definitely bring the retriever, the fact that these devices could be extracted or retrieved and replaced. And honestly, and maybe it's the same experience, like retrieving these devices is probably easier than one would envision when you put them first. So this hasn't derailed me from considering these devices even for younger patients.
Well, I have to say that we don't have a lot of experience retrieving these. I guess the retrieval experience comes from retrieving the nanostim devices, which was the early predecessor for this device. But this is a patient that had a VAR that needed an upgrade, and the patient actually wanted to take his VAR home, so we had to retrieve it. That was the only reason. Having said that, I live in Arkansas,
Only in
so
Arkansas.
you can see it's a tri-loop snare, so there's a retrieval catheter. You can see that the handle of the catheter is pretty much similar to the delivery catheter, so the ergonomics is a little bit easy, but it's a tri-loop snare. It has that nitinol sleeve. I like the nitinol sleeve as a dissector, almost breaks up all the adhesions. Not that there's a lot of adhesions, but usually once you dock it, you can do about three turns of counterclock rotation and take the device out. And I'll let the team play the next video as well while we have a discussion on retrievability. Rahul and Vivek, you guys have had a lot more experience with retrieval.
Yeah, no, look, our experience has been exact. In fact, the whole world experience is the same, which is that it was surprising to me how easy it's been to retrieve these devices. And, I don't want to be cavalier about this, but the fact is, if you're going to be cavalier about something, it's probably this, because they've done a good job with the retrieval catheter, so that once you grab on to the back end, which is surprisingly easy, and you dock to the device, then as you rotate, you have a lot of let's say you have a lot of capability to rotate the device, and that's all that's holding it in place. So the only time you really fail, which is typically in the ventricular device, is if they're laying flat, for example, on the floor of the right ventricle. Then what can happen is you have you have fibrous tissue that builds up over the device. So when you inject contrast, you'll see that the contrast doesn't actually touch the device. You'll see that there's something covering the device itself. In fact, my colleague Peter Nuzzel, they had a very nice manuscript a couple of years ago that if you simply look at the leadless pacemaker on X-ray fluoroscopy, the devices that are moving with each heartbeat, sort of going like this with each heartbeat, you'll be able to remove. But if they're just still with each heartbeat, just sort of doing this, then you almost certainly will not be able to remove them, because they've been sitting down and they're covered with fibrous tissue. But then, of course, who cares, right, at that point? The other interesting thing about these devices, I think we're learning more about the atrial devices, because I think there was some concern initially when you try to retrieve these devices, you have problems retrieving the atrial device because the tissue is thinner and blah, blah, blah. But I think what we're finding is that, no, it's actually just like I suppose retrieving a conventional atrial lead without all of the problem. Actually retrieving the lead.
Yeah.
The distal part actually ends up coming out pretty easily. So I think, can I ask, let me ask Rahul, what has been your experience? You've also done a lot of retrievals too.
I mean, I would completely agree regarding the ventricular experience. Of course, that is predicated on the fact that these were nanostim devices. But, like Peter, I've taken out a 9-year-old device and came out in minutes, right? If it's free, if you can access the docking button, it's unscrewed, and it's as simple as that. The atrial device, have taken a few out. The longest was a little over 2 years. And that was for a device that was implanted with the high threshold. And it came out in minutes all as well. And I do think this just is proof of concept that the helical fixation is infinitely safer when it comes to retrieval. And so I think that, sure, we need more experience with the atrium. We need long-term experience with the atrium. But having said that, thus far, everything is very promising, I think, that this is a retrievable device, A and V. And, I think that does emphasize the fact that these are important devices to consider in the younger population, as Mikhael actually alluded to. I think that's a very important consideration.
Well, thank you, Rahul and Mikhael and Vivek, for your insights. And there's still plenty of to come today's program. So I'll see you back in a minute. Thank you very much, guys.
Thank you.
Thank you.